Okay, well, we're going to kick off. Peter Drobac has now become a familiar face to everybody who needs to think deeply and thoughtfully about all things Corona. Uh, I'm I'm desperately hoping for the day that we get you to come and talk about public health in the non-Corona context in the conduit, because you have so much more to give in that area, and all your important affiliations with Skoll as well, which are really, really important. But maybe that day is not that far away, so we'll think about it. So Peter, I wanted to start, we're going to talk a little bit about lockdown, and then I'm going to do a little bit of a sort of conduit conversation, just to kind of talk a little bit about that as a way of thinking about hospitality and opening up, and what may be not too far around the corner. But before we do, can we just sort of knock out some of the usual things that I always like to talk about, both treatments and vaccine, some of the things that you think are worth noting? There's a French study about immunity with people who got mild symptoms that's worth talking about, and then some of the kind of treatment and vaccine stuff. So over to you.
Sure. Sort of updates from the scientific literature from the last week. We can start with that French study that you mentioned, and a few related things. So that study basically looked at people who had mild infection with COVID-19 and recovered. And what it found was that in essentially all of the people that they studied, that they developed an effective immune response with what are called neutralizing antibodies. Those are the antibodies that could actually neutralize the virus. That's a sort of fancy way of saying they showed evidence of an immune response. And that was about 4 weeks out. So between 2 and 4 weeks, you would see the sort of antibody levels rise to a level that looked meaningful. This is important because we've been saying we don't know how much immunity you get, or if everyone gets it after infection. And we don't know sort of, if you do get it, how long it lasts for. This gives some answer to the first question. We worried that it might only be the people who got really sick who would then mount an effective response after they recovered. This suggests in milder cases that that's also the case. So that would be great if everybody who gets this and recovers gets some immunity for some period of time. There are a few other studies that I've seen, including one published in a US cohort with 168 patients, ranging from mild to severe. All of them developed some antibody response as well. So that's good news. We don't know if that lasts, but that's good for down the road as more people get infected, having some level of population immunity. And it also bodes well for the potential efficacy of viruses, or vaccines, excuse me. On the vaccine front, couple things. The Oxford vaccine, we've all been watching very closely. No real news on results yet, but there's a little bit of bad news and some of the good news out of the UK, and that are the number of cases in the country has declined significantly now over the last couple of weeks, such that it's getting more difficult to be able to tell if this vaccine works. What needs to happen, because you're giving a group of people the vaccine and a group of people a placebo, you need to have enough people at least getting the placebo, getting COVID, that you can tell a difference between the two groups. If very few people in either group get COVID-19, you're just not going to be able to tell if it works or not. And so actually more cases from the purposes of the study is a good thing. And the fact that we're in a good place now makes it difficult. So they're saying there's a 50-50 chance that they won't be able to actually get a meaningful result from the study as it's currently planned. And they're just about to expand to the next phase, which is enrolling 10,000 people. Now that may, because they're going to be enrolling folks in care homes, and they've, I think, expanded to health workers and some groups that have been higher risk, there may be something to that. But what this means that there's a chance we may not get the results, positive or negative, as quickly as we wanted from that vaccine. So that's disappointing, obviously, but at least it comes from a good place. We talked about some of the vaccine news last week. There's a sort of another vaccine from China that's similar-ish to the Oxford one that also showed some promising, extremely early results. So we have 3 different vaccines that either in humans or animals showed that they seem to be safe in really small numbers, and that they seem to show that they generate neutralizing antibodies, which is a proxy for them giving you protection. So that's good. We saw Anthony Fauci, the head of the National Institutes of Allergy and Infectious Disease, and the sort of the top, sort of infectious disease doc in the U.S., one of the preeminent of the world. He's sort of the PRP out of America. He's been quite cautious on this, and he's over the last week said that if everything goes well, he could envision a vaccine becoming available by the end of 2020. I was surprised by that, and it's meaningful coming from him because he has so much credibility, and he's seeing some of the data that the rest of us are not seeing because it's not published yet. I worry that we're going to get overly optimistic about this, but again, it's meaningful coming from him that at least there's a chance if all the stars align. By no means a sure thing.
So can I talk about the UK in particular? I mean, the good news, bad news, it must in balance be good news that the level of infections are dropping. I presume that means the R is generally well below 1, we now think.
The published data have suggested that the R has been between 0.7 and 1, and that's held steady for the last 2 to 3 weeks. It should always be a range because obviously it's an estimate, but it has not gone up according to the government reports over the last couple of weeks, even as we've presumably seen a bit more sort of mobility and easing of lockdowns and things like that. It's still early days.
So I guess the question then is if the R is between 0.7 and 1, and it remains there, how arithmetically and just sort of coming epidemiologically, how quickly does it die when it stops replicating? Because in some ways, is the hockey stick, the inverse hockey stick of it growing exponentially, does it not also die exponentially because you get fewer and fewer cases and fewer cases are not spreading? Does it mean that you don't have the plateau, but you actually have a cliff in decline?
Yeah, and we saw a plateau for a long time, and then it's really finally started to tail off. Again, the daily cases is a little bit hard to interpret because we still don't have mass testing everywhere, right? We still don't have a lot of community testing. So even the government estimates that we're still seeing, I think it's like 6,000 infections a day across the country, which is much higher than the number of reported cases because we're not testing enough yet. But of course, we've seen that decline in hospitalizations. We've seen that decline in deaths. And so that's all really good. I think you have to get pretty low on the R before you see a real drop off. And we have to remember that this is, our lockdown was by no means the strictest possible version of the lockdown, right? In China, the R was down to about 0.3, and that was strict when you had to get a pass to go out and do your weekly shopping, right? And one person could get 1 pass a week, and you had to get your temperature checked before you went out, before you went into the shop, before you came back, etc. Nothing like what sort of we had here. I think if we can hope that as things ease up that we're going to stay close to 1. Evidence from other countries that have been easing up before us suggests that this is a real tightrope, that you're kind of on a knife edge, and there's sometimes you're going to tip over and you're going to start to kind of see little flares. I don't think that that saying we are going to extinguish this and get it to 0 is going to be a real possibility here or probably in most places. We're just never going to be able to get to that kind of strict social distancing, and we don't have other containment measures like testing and tracing in place to do that. So I think the most likely better case scenario is that we continue to see a decreasing but ongoing number of new cases, and there are going to be little clusters that are going to have to be tracked and extinguished.
So never going to be MERS or SARS or Ebola because it's just got such a high infectiousness that it will be in the population for some time to come. So the most optimistic world we live in is we develop pretty effective treatments. When you get it, you get pretty sick, but if you get quick enough, it stops full-blown pneumonia and hospitalizations and having to go into a ventilator. And then we have enough people who are vaccinated such that it's not wildly prevalent. And that will be the new normal.
Yeah, I mean, there's I think before that, or the other scenario is that if we were doing mass testing, if everybody who needed a test could get a test, if kids in schools could occasionally get tested, people in the workplace when needed could get tested, and we had the army of contact tracers, and we had systems for isolating people who either were positive or were contacts to be isolated or quarantined, and we were strict and effective about that, then you would see a scenario like South Korea, where they do see some days with no new cases, and occasionally they have blips. Like yesterday in Korea, there were about 40 new cases associated with a single kind of outbreak in a bar. So there's a lot further we could go. And the other way of decreasing the R is not social distancing and lockdown, it's interrupting chains of transmission with test, trace, isolate. So we've heard lots of talk about that. We haven't seen it. Yet. The app is not working, and that's not coming out. We're still told as of today that the contact tracing army is going to be deployed as of Monday. We'll see what happens. Testing has been plateaued now for several weeks, and it was declining a little bit, and over the last 4 days, they just stopped publishing the testing figures. Claimed, I don't know, the Prime Minister claimed he hadn't noticed and doesn't know what happened. But we're not testing all the people we need to be testing, even as we contemplate opening schools in a couple of days and starting to open businesses and things like that. So that to me continues to be a failing, and that's the critical recipe for us to be able to start to get back to normal without seeing the kind of flare up. So in that way, I wish we were in a way better place than we were a couple of months ago. I'm not sure yet that we are.
So schools will know tomorrow whether we affirm that they will in fact be opened. And then is that right?
That was my understanding. The Prime Minister the other day said it's happening, and kind of preempted that. So I think it was in his remarks on Sunday after Cummings' presser that he said that they will open on June 1st. So I'm a little bit confused by that. What I've been told locally here is that was the message that they got. So there's going to be, at least on a locality by locality decision, but some schools are going to open, is my understanding. But it's not been the most clear messaging.
Unclear messaging and inconsistent applications of the rules all the way to the very top. A case study in what not to do when you're dealing with this crisis. So stores reopen in the 15th of June. They need to be Corona certified. That will obviously, for already besieged retail models, fashion in particular will be wildly difficult. I mean, I saw a story yesterday that you can go into a store to look at clothes, Marks and Spencer, you have to walk in a particular order, you're encouraged not to touch the clothes, and you certainly can't put them on, which must be a suboptimal experience from a customer point of view, and it's really a challenge, right? There's certain sorts of things where in this format, online is just infinitely preferable, especially in a world where you can order and return free of charge and no extra delivery fees, which has a whole set of climate consequences. But let me ask you a question about the next wave. And obviously you're a dear and valued member of the Conduit, and we're sitting down and contemplating when it is that we start recongregating. And of course, there are a set of questions that you say, informed adults can and should be entitled to make decisions about how much proximity they have with each other. How do you think one should go about, one of the core things we do is bring people together for events, incredible world-class speakers sitting with 100 people in a room. Do you think that for a time is just irresponsible, and that one should be having a half or a third of the number of people in a room, and that you just shouldn't do it? So how do you think about businesses which have proximity as part of their offering?
Yeah, it's such a tough question or set of questions. And I think first thing we have to understand is there's a whole spectrum of risk, right? That different types of establishments and different kinds of activities are not created equal, right? So one thing we know is that if you're going to have any kind of mingling or interaction or proximity, being outside is way better than being inside. Some of the most recent data suggests that the risk is about 19 times lower outdoors than it is indoors, just because of natural air movement and airflow. And there have been very few examples of the kind of super spreader type events from outdoor contact. So that only helps in certain kinds of places. There are only so many outdoor markets and things like that. For what it's worth, an easy place to start is to do stuff outside when you can, or to have as much kind of, you know, natural ventilation as you can in those spaces. The highest risk kinds of settings are when you're going to have a larger group of people in close proximity for a period of time. And that's why we've seen these kinds of little spreading events in places like church services, right? Because you're going to have 50 or 100 people sitting in an indoor enclosed space for a long period of time, and then doing a lot of talking and singing just increases that risk even a little bit more. So those kinds of spaces, and then things where you have to be in like direct proximity, like hairdressers and nail salons, those are the sorts of things that, you know, to me, it's just hard to see how that's going to be able to be done sort of without any risk. So, you know, we've been thinking about some of these same questions that you have at the Conduit at the university, because, you know, we bring people together in rooms for 90 minutes at a time to do lectures and things like that. And what sort of we're determining is that first, when you actually do the space planning and say, for this given space, if we want to make sure we maintain a 2-meter distance between each seated person, that is, you know, it becomes only a fraction of the available space. So 100 capacity room might actually be 18 or so people that you can sort of do that with some kind of reasonable safety. Then you have to say, well, is it worth it to hold an event when there's that few people and they're sitting so far apart? Is that weird? So I think with some of those events, those are considerations that are going to have to be made. You could see in other spaces where people are kind of coming and going and mingling that you could reduce the number of tables and frequency. You increase hand washing stations. Some places are using barriers and things like that. Doesn't create the warmest vibe, but it can be done with, you know, some degree of increased safety. You know, the other big consideration, I think, is not just about the people coming indoors as patrons or guests making their own decisions, but employees, right, who are there for their work, who are being asked to work or not to work, and making sure that we're doing all we can to protect our employees, to put them in positions where they're not going to be compromising their health, understanding that some may have medical vulnerabilities or family members who do, and might need to, you know, maybe not be put in that situation, at least for a period of time, or put into lower risk operations, and having access to masks and things. I got to say, as an aside, I was so confused why everybody's not wearing masks all the time in the UK as we start to get out and about, because here the science has become pretty clear that mask wearing prevents the spread, right? It protects me from infecting you, not from getting infected. It prevents me from asymptomatically spreading it to other people. And that's become de rigueur even in the US, but here it hasn't. And I look back, and on something like May 12th, it was made a recommendation or an instruction, so it was made policy, but somehow that just got lost in all of the muddled messaging, and no one's talking about it, and very few people are doing it. So it's surprising to me that we're not all wearing face coverings, you know, not medical, but cloth masks when people are out in the supermarkets and the shops and things like that. You know, I think that should be probably the norm. Again, certainly for employees, but probably for others who are going to be in these spaces as well. So those are some of the considerations. I think it also makes sense to probably to kind of start slowly and to learn. And I'd feel a lot more comfortable if we had testing and tracing in place, you know, as we start to do this. So we can hope that'll be the case once we hit that June 15th date, but I don't know yet.
So that Keith asked us precisely this question, but if you could create a social norm that everybody for the next 3 to 6 months just wore masks, you know, how significant do you think it would be in terms of dropping infection rates? And would it in fact be as effective as social distancing and lockdowns? And in fact, you may be able to have people in closer proximities in rooms for an hour if everybody agreed to wear a mask, to listen to a lecture at the university, or to go to an event or a talk. It seems to me to be a kind of a no-brainer, just to kind of say, look, that's the trade-off that we do for getting back onto public transport and beginning to kind of emerge from lockdown.
So I don't think it could replace lockdowns or extreme social distancing in terms of effectiveness. We don't know exactly, the kind of non-medical face coverings themselves haven't really been studied. Obviously, there's lots of different materials and thicknesses and consistencies. We'll see more data coming out over the next weeks, I think, about some of those things and which kinds of coverings work best. To be honest, if they cover your entire nose and mouth and they're comfortable enough you can wear them for a long time, that's going to sort of go a long ways. It's going to be incomplete protection, but if that were to reduce the risk in sustained interaction by 50%, that's a significant benefit, both from an individual risk perspective, in terms of being out and about, but also from a population perspective. And so I'd love to see whether that's being modeled as they start to look at, how different kinds of changes are going to affect the R. But it seems to me the evidence now is clear enough. And it wasn't clear to me back in February that would be the case, before we knew how easily this was transmitted, before we knew that there was the possibility for some aerosolization and things. But it now seems to me to be a no-brainer that people should be wearing face coverings when out and about as a norm.
Dominic asked a question about plans to measure antibodies over time to see how long they last. And first, just kind of factual question, are there trials or consistent studies afoot to kind of keep going back to see how long the antibodies endure? And then I guess the ancillary question is, given in many places how few people actually, I was reading it's way lower in the Scandi countries, way lower than 10% in all of them, right? And if that's the case, bodies of resistance, if everybody got full resistance for 20 years, you still have 90% of your population who, absent a vaccine, have nothing. So I guess the question is this question of resistance much ado about nothing, or is it really of public health consequence?
About resistance?
About the antibodies that would emerge that would give you resistance.
Yeah. So first point, I'll start with your last point first, because I think it's really important. Think about the human toll that we've experienced just in this country in terms of mass casualties, right? 40-something thousand, possibly as high as 60,000 if you include all of the excess deaths, to get to 4% or so of the population with probably some degree of immunity, right? And we know that a kind of population level protection is at least 60%, if not a little bit higher. So it's just hard to imagine a scenario we can get anywhere near that with an acceptable level of suffering and death. And you're right that how long would it take to do that in a way that we could tolerate it? So if these antibodies are going to sort of wear off within several years, as certainly may be the case, that's just speculation. There's not a scenario that's going to happen. So if there's anybody still out there talking about herd immunity as being a not insane idea, I think that that should hopefully put that to rest. Now to Dominic's question, which is a really, really good one, the answer is yes, absolutely. So there's a lot of studies that are going to be ongoing that's going to look at how long this lasts. The studies that we saw are typically looking at about 4 to 6 weeks, but for the very first people ever to get infected with SARS-CoV-2 got infected, we think probably in late November, early December, so we're only 6 months out now. But over time, we will learn more in following people longitudinally how robust and how long lasting that immunity is, or those antibody levels. We'll be able to learn more about what levels of antibodies correspond to actual clinical kinds of immunity or risk from reinfection. So we're going to learn a ton more, but obviously it'll take time. It'll take time to do that. One other thing to point out, though, in terms of other news from this week, is that the CDC, the U.S. Centers for Disease Control, just made an announcement that up to half of the antibody tests that are currently out there in the US right now might be giving inaccurate results. And they're mostly false positives, where it suggests you have antibodies if you don't. So we continue to have quality problems with antibody tests, especially those that are not being done in the kind of, laboratory setting with something called ELISA. So there's this huge kind of promulgation of antibody tests, and you can go online and people can mail them to your house, and you get tested for a couple £100 yourself. But the government obviously famously bought millions of them here only to find they didn't work. That's still a real problem. So we're in a space now where we don't know enough about antibodies, and our testing isn't reliable enough that the notions of immunity passports and things look like they're not going to be a short-term fix for us.
But I come back to your first point. In some ways, if your percentage of people infected are significantly less than 10% and closer to 5%, it's of some relief to a tiny percentage of people. And it's not of no consequence, but it is not the big picture solution that one can seek any public health comfort from.
That's right. If I had had a COVID-like illness, I would really want to get an antibody test that I thought was going to be accurate. And it would be nice to know that I had evidence of what should mean some immunity, right? That's obviously very meaningful. But that's sort of at the level of kind of planning how we get back to work and what that means at the population level, we're not quite there yet.
So with vis-a-vis the return to school, a couple of weeks we've discussed the kind of Kawasaki or more scary immune response, COVID condition in kids. It seems, maybe I haven't been paying as much attention, that there's been no step change increments in this area in the last week or two. But tell me if there's any other news about this mysterious syndrome and our levels of concern about it.
Not too much that I've seen. Last I saw is up to a couple of hundred cases reported across several countries, which is still going to make it relatively rare, but we don't have a denominator. So we can't say 1 out of 1,000, 10,000, 500 children will get this syndrome of sort of those who get infected. We just don't know at all. So it remains rare, but still something that is significant, mostly in that it, to me, is like this niggling reminder of how much we don't know, right? There have been autopsy studies now that look at where the virus is and finds that in people who have died, it's not just in the lungs, it's in the brain, it's in the heart, it's in the kidneys, it's in the liver. We're hearing reports about sequelae of all other kinds of problems folks are having after this disease. There's just a lot that we don't know about COVID-19 yet, and all of those things give me pause. There was some new data this past week that suggested that from contact tracing, large-scale contact tracing kinds of data, that children appear less likely to be infected if there are contacts of an infected adult than adults, about 58%. So that is some evidence to suggest that maybe kids are a little bit less likely to get infected when they're in contact. That's not definitive, and there's a lot we don't know about how much they can spread it. So, there's ongoing evidence that kids are at a lot less risk. We need kids to be in school. I get it. I just still am in this place where I feel a little bit too uncertain about that.
Final question. I read a study. They did some stuff on genetic predisposition to dementia or to Alzheimer's, and saw that there was a very high correlation between people who had this gene and high levels of COVID, either illness, hospitalization, or mortality. And that really struck me as another one of these bizarro things about this thing, that there are one could have a correlated genetic predisposition to particular vulnerability in this. And A, have you read anything or been following anything in that regard? And B, as we discover more of these things, do they help give us breadcrumbs and clues to sort of see how we may be able to fashion a vaccine or a treatment?
Yeah, so I did see those studies. I think the same group had first found an association between patients having dementia and then higher risk of severe disease or death from COVID-19. And then they dug a little bit deeper and they found association. There's this particular gene, there's many genes associated with Alzheimer's. I mean, I think hundreds, but there's one in particular that has been known for a long time. That's one of the more common ones and has been a target for therapeutics called ApoE4. And they found an association between that gene being present and more severe disease or death. And when you do that, you try to control for other stuff to say, well, those people more likely had dementia, and people who have dementia had all kinds of other health problems, and that may have predisposed them to get really sick, or maybe those people are going to be a lot older. So they tried to control for those things and found that there was still an association. What does it mean? I have no earthly idea. There's not that I know of a particular biological sort of pathway to suggest that, this is what the causal connection would be. But that's a great area for study, and obviously will be dug into a lot more. It's one of those things now, especially with the kind of capabilities that we have with big data and things, where you can throw a whole bunch of stuff at the wall and see what sticks, and then take those associations and dig into them. And that's exciting, but it's also potentially really misleading, right? Because if you don't have a plausible pathway, there's no reason, you can say like, I clapped my hands and this thing happened over there, and that's an association. We talk about statistical significance being less than something called 0.05. That means there's less than a 5% chance that this association happened by chance, by accident. So what you're saying is that 1 out of 20 things that you think are significant are not going to be significant, right? So this may turn out to be nothing, a breadcrumb that goes nowhere, but it could be interesting. And there's just such an insane amount of research that's happening right now. One of the big challenges it's sifting through in figuring out which is meaningful.
So Peter, I'm going to end now, but I think in the next couple of weeks, since schools will be back, I'd love to sort of just lay down a marker in our conversations for us to start to have a conversation about when school goes back, what is the data that emerges a week or 2 weeks thereafter that should make us feel reassured or should make us feel extremely concerned? And what is that going to do in terms of spread and lockdown? And I think it will be a live conversation next week, Wednesday, the Wednesday thereafter, and the Wednesday thereafter. And it would be good to kind of kick off next week with sort of thinking about how we answer that, so that as citizens and as parents, we can approach it in a thoughtful, data-driven way.
I hope the data are there. We'll look forward to talking about it.
Lovely to see you as always. Thank you so much.
Thank you. Cheers, everyone. Stay safe.
Stay safe and stay well. Bye.